Hello, greetings from Canada. My name is Ashok Bhaseen, and I'm president of Thyroid Federation International, a global patient organization. Um, Thyroid functions disorders in diabetic patients is the topic today. Before I go further, I'm not associated or paid by any company for this presentation or for my work that I do to serve the thyroid patients. Before we proceed, I think it'll be important that we understand the meaning of my topic today. So, thyroid function disorders in diabetic patients, what does it mean and what do I want to convey? Both thyroid disorders and diabetes fall under the endocrine system and endocrinology specialty among physicians. Why and how the duality of endocrine issues is important for the physicians and the patients they are treating. So, this is something that we are going to discuss. And do doctors usually tell the patients, for example, doctor knows the best, or should the doctor and patient team up for the best outcome? So, this is something that often a lot of doctors say, no, I know the best. You don't tell me what is the issue. So, I'll take care of it. The other thing is the world has changed, and the patients come very prepared when they have been diagnosed with endocrine issues, and therefore it's a different ball game today when it comes to treating patients. They are also very knowledgeable in what they have, and they know a lot. So it's important that we have a dialogue rather than just monologue with the patients. So these thyroid dysfunction and diabetes mellitus, these are two closely associated disorders. Thyroid dysfunction and diabetes are very closely linked, both in the endocrine system, and several studies have documented the increased prevalence of thyroid disorders in patients with diabetes and vice versa. So it is not something that is new. I'm sure all of you know this, but this is something we're going to discuss. The review, and you can see the reference here below, uh, is provides critical discussions on different underlying mechanism, which is linking type 1 and type 2 diabetes and thyroid dysfunction. That demonstrates the association of these two common disorders uh, and is unlikely a simple coincidence. So, not just a coincidence, but this is a fact, and this is what we will look at the duality of these two. So, this is something, it is established fact and not just a coincidence. Thyroid issues and diabetes. So, part one of this autoimmune thyroid dysfunctions, they occur in 17 to 30% of adults with type 1 diabetes. And thyroid dysfunction is more common in patients with type 2 diabetes than in the general population. So, this is something I want to emphasize here. It is quite common when it comes down to patients with type 2 diabetes, that both thyroid issues and diabetes both exist in them. And pre-existing diabetes mellitus is exacerbated by hyperthyroidism. And insulin treatment should be adjusted in patients with diabetes after the occurrence of thyroid dysfunction. So this is very important here that the insulin treatment and the dosage needs to be adjusted when it comes down to patients which have this duality of thyroid issues also. Hyperglycemia should be re-evaluated in hypothyroid subjects after the control of thyroid dysfunction. So, it's important to look at the readings. Also, it's important to listen to the symptoms of the patients. So, it's both, not the one, because we don't just treat the readings, but we treat the patients. Therefore, it's important to also look at the symptoms of what the patient is talking about. Liraglutide is not recommended in patients with personal or family history of medullary thyroid cancer or type 2 multiple endocrine neoplasia. Pioglitazones should not be administered to diabetic patients with clinically active Graves' ophthalmopathy. Let's now talk about metabolic changes and glycemic control in patients with TD and all diabetes mellitus. Glucose intolerance in patients with hyperthyroidism is prevalently due to hepatic insulin resistance because the thyroid hormone excess increases the endogenous glucose production and insulin requirements and reduces hepatic insulin sensitivity. So these are the things that happen when both thyroid issues and diabetes mellitus are together. We have to look into this and adjust accordingly. This is a diagram. Most of you must have seen this diagram. So there is brain in between, and then you have TSH release from there, which impacts the T3 release, and white adipocytes and brown adipocytes. And then you look at the glucose uptake on the left-hand side, and glucose transfer, glucose utilization, glycolysis, energy expenditure, UCP3, and on the hepatic side, glucose output, glucogenesis, glycogen synthesis, insulin sensitivity, intrahepatic lipolysis, and then on the insulin side, you see the gut hormone glucose absorption is increased and increased insulin production, etc. So diabetes and thyroid disease are both endocrine or hormone problems. When thyroid disease occurs in one with diabetes, it can make blood glucose control more difficult. And this is something that we are talking about. Thyroid issues and effects on diabetes. The other part is let's look at some of the things like hyperthyroidism. For example, Graves. In Graves, this is a hypothyroid condition where overproduction of thyroid hormone happens. So what happens with that? When your metabolism quickens, your medicine go through your body much quicker, and your blood glucose levels may rise because your usual dose does not stay in your body long enough to control. So these are the things that happen when both hyperthyroid condition and diabetes is present. Hyperthyroidism and low blood glucose can be hard to tell apart. This is the tricky part. It's hard to tell apart. And if you are sweating and having tremors from hyperthyroidism, you may think you have low blood glucose and eat extra food. Now, we're talking about the patients, that's how they think, causing your blood glucose to rise. So, this will increase the blood glucose. Using your glucose meter to verify blood glucose levels can help you to avoid this problem. So, that's what patients do. They look at and measure their blood glucose and see. And you can ask them for the reading. Nowadays, with all the gadgets available, uh, these things are also on their phone, and they can show you the glucose levels and the readings when they do the testing. And this is something it's important to tell the patients to bring this along with you because that helps. You as a doctor are not there with them all the time, but they know what happens and what the readings are, and that helps you to evaluate the patient better and adjust the dose both with insulin and also with levothyroxine with this dual condition. Now, hypothyroidism, and this condition of hypothyroidism, when your metabolism slows, your blood glucose level may drop because your diabetes medicine doesn't pass through your body as quickly as usual and stays longer. So, this is when we are taking, for example, levothyroxine. In hypothyroidism, it is often necessary, therefore, to reduce your dose of diabetes medicine to prevent low blood glucose. So, of course, here we're talking about metformins, we are talking about other blood glucose monitoring system and also insulins. Now, These are the symptoms of hypothyroidism on the left-hand side and hyperthyroidism on the right-hand side. So symptoms like thinning of hair loss, loss of eyebrows. So in this case, broken hair and hyperthyroidism and hair loss. The hair loss part is common but slightly different. Now, in hypothyroidism, puffy face, enlarged gland. In case of hyperthyroidism, it is nervousness, irritability, insomnia, depression, and then dry skin, coarse skin, slow heartbeat, whereas the heartbeat is increased in the hyperthyroidism side. And constipation, infertility, heavy menstruation, cool extremities, carpal tunnel syndrome in case of hypothyroidism and hyperthyroidism, warm, moist skin, increased body temperature, muscle cramps, and muscle weakness. Now let's look at this further and see what are the common. So you see the red arrow in between. The common part is fatigue, insomnia, hair loss in both the conditions. But otherwise, the conditions are totally different from each other in case of hypothyroidism and hyperthyroidism. So in hypothyroidism, for example, weight gain is there, but in hyperthyroidism, weight loss is there, but sometimes weight gain can also be there. So these are differences, and these are important differences to note down when talking to the patients. Other situations, this is more clear here. If you look at hyperthyroidism, increased food intake, and hypothyroidism, absorption of glucose decreases. Then, in case of hyperthyroidism, increased glucose absorption is there. In hypothyroidism, the post-absorptive glycemia takes place. Increased hepatic glucogenesis in hyperthyroidism and decreased hepatic glucogenesis in hypothyroidism. So I'm not going to go through all those conditions, but you can see in one side in hyperthyroidism, something could be increased, but in hypothyroidism, that is decreased. So it is just the opposite, more or less, hyper and hypothyroidism. And in hyperthyroidism, increase in insulin requirement for diabetes patients. And in case of hypothyroidism, there could be decreased insulin dose in diabetes patients. These are some things that we need to adjust for the patients. Let's look at metabolic changes in patients with hypothyroidism and effects on glycemic control. So in hypothyroidism, it is characterized by impaired glucose absorption from the gastrointestinal tract or delayed peripheral glucose assimilation, decrease or a normal hepatic glucose output, and reduced liver and muscle glucogenesis and glycogenesis, glycogen losses. Sorry. Insulin secretions have been reported to be normal and increased or decreased, and the insulin half-life cycle is prolonged. In rat models, adipocytes and skeletal muscles of hypothyroid rats are less responsive to insulin, and then decreased glucose transport in myocytes, and glucose utilization is slowed in the peripheral tissues. The rate of glucose oxidation and glycogen synthesis are decreased in hypothyroidism. The inability of insulin to sufficiently maintain glucose utilization by the muscle leads to insulin resistance in patients with subclinical and overt hyperthyroidism. So this is also tricky when it comes to subclinical hyperthyroidism and overt hyperthyroidism, as it may be called. So this is, we often look at the readings and we place subclinical and reading where it is 4, 5, 8 to 10, and sometimes we say, oh, patient doesn't need to be treated. But again, it's not the readings that we treat, it is the patient and the symptoms what they tell us that we treat. Therefore, it's important to look at that and also look at subclinical situation and adjust the dosage accordingly. Several studies have demonstrated higher insulin levels in hyperthyroidism with a lower insulin clearance. And insulin resistance in both fasting and post-glucose conditions have been reported in patients with overt and subclinical hyperthyroidism, with a positive correlation between the TH and the Metasuda index. The pathogenetic mechanism leading to insulin resistance in hypothyroidism may be related to dysregulation of the leptin action of the hypothalamic level, the impaired GLUT4 translocation, and the increase in free fatty acids. Insulin-stimulated glucose transport has been found to be decreased in isolated myocytes from patients with overt and subclinical hyperthyroidism due to impaired translocation of GLUT4 glucose transporters on the plasma membrane, suggesting similar changes in peripheral tissues. Thyroidectomized patients have insulin resistance even after acute LT4 withdrawal. In other case, in glucose-induced insulin secretion by the beta cells is increased in hyperthyroidism and reduced after LT4 therapy, which is levothyroxine therapy basically. The insulin requirement is decreased in insulin-treated patients with diabetes developing hyperthyroidism because of the impaired renal insulin clearance. So, this is also an important factor where the renal insulin clearance because of impairment changes the dosage requirement. Therefore, during treatment with insulin, patients with hyperthyroidism, with uh, uh, DM required decreased insulin doses with exogenous insulin is not decreased, and symptomatic hyperglycemia can occur. Uncontrolled and untreated hypothyroidism, for example, overt or subclinical hypothyroidism, may induce recurrent hypoglycemic episodes in treated patients with T2D and a reduction in the insulin dosage. This should be considered to prevent hypoglycemia. So do consider reduction of insulin dosage for this situation. As a result, insulin doses should be modulated with correction of hypothyroidism, and insulin requirement should be assessed in the light of increased risk of hypoglycemia. So the conclusions are that we treat patients and not just the readings of the test results that we get. It is important to listen to the patient's symptoms. It's also important to look at the test results and then adjust dosage accordingly. Condition like renal impairment and other symptoms. These are all important things to be taken into consideration where dosage adjustments are required. Comorbid conditions with thyroid issues and diabetes may need dose adjustments of insulin and or levothyroxine or both the situations. Again, we got to look at the readings. We got to look at uh, the diabetic patient reading also glucose levels and see how it is fluctuating, changing over the months, over weeks, over days, and then come to some conclusion in terms of changes of the dosage. I think talking for the patients, teaming up for treatment with patients may produce better results. A lot of times we hear patients telling us that the doctor says, oh, the doctor knows the best. I know the best. You don't worry. I will take care of it. I think it's important to listen to the symptoms and or changes what they go through. Also look at the readings and make conclusions rather than just saying that I know it and I will do according to the results of the test. So I think it'll be important to consider both. Now, doctors are not usually patients. Sometimes we are, but doctors are not usually patients. It's good to listen to the patients and provide appropriate dosage and adjust dosage when needed. So this is something that I want to share with all the endocrinologists, and consider listening to the patients, teaming up with the patients for the best outcomes. Thank you very much, and if there are any questions, I'll be happy to answer. Thank you, and bye for now.